So whenever I have these two mics, I suddenly start feeling like Rahul Gandhi. I don't know why. And I said that before also. So one of the things is that just because I ask questions, please don't ask me questions. That is the other disclaimer that I have. I actually have only 2 minutes to present because I was supposed to finish by 10:25. So what I'll try and do is, let's try and save time. So I had about 20 slides, and I'll focus on the ones which are important and try to finish in 10 minutes so that we save time, and I think we should finish on time because नहीं तो ऐसे ही चलता रहेगा. So the topic is slightly boring. Let me see this is just one quote from Albert Einstein saying that why you need to not only outcomes but why you need to assess outcomes. So this sort of becomes different from karmanyevadikaraste ma phaleshu kadachana. It's actually the results which count in disease. This is the outline of my talk: history of outcome measures, patient-reported outcomes, subjective complaints, what are the domains. SDI and SPRI are going to be the focus, and applicability in the Indian setting. This is the OMRACT symbol, the outcome measures in rheumatoid arthritis clinical trials organization. We all know the ideal outcome measure. These were early on in 1980 by this particular gentleman who was from Stanford, and this is a laser. Is this a laser? Okay. And so we all know that ideal measure should have ethicality, which means it has to be, the value has to be enough from the past ones which you've had. Validity is it measures what it is supposed to measure. Reliability is when you use it again, it gives the same result. Responsiveness, it measures the difference, minimal difference between, and then you have to pass through these filters, and these are the main domains. So for a very long time, and we know that with the background that 20 to 40% of primary Sjogren'S have systemic features. Now before 2007, essentially it was the patient-reported outcomes which were measured because we didn't have much in treatment part. When we got rituximab, the stakes became higher, and that is when we needed another outcome measure to quantify when to use it. This is the table which summarizes the different outcome measures. I'll be going into some of them, so you may not look at that. And these were the timelines of when these outcome measures were actually made. So the first one is the profile. This is for fatigue and domain system. This is the Sjogren'S systemic Sjogren'S inventory. The short form. So the original profile had about 64 items. It was very lengthy, and so they brought the shorter form which had 8 domains and 19 items and used it. This is used as a secondary endpoint. You need a difference of at least 1 point or minimal clinical important difference of 15%. It was validated properly, and this was one new paper. I would like all of you to focus on this new paper which just came, which is now brought back profile again, because what people are saying is that although to clinicians the systemic symptoms may matter, to the patient it is the patient-reported outcomes which are important. And what profile covers, none of them cover. So you can look at this. This was a series of 46 patients. Out of 40 gave importance to oral dryness, 34 gave importance to ocular dryness, here cutaneous, vaginal. So these are all the profiled items which are listed here. And this was the triggers that affected and impact. So the patient-reported outcomes are really important. This was the short form, which is the profiled SSI, and this is just to show that both of them were equal in terms of their application. This is the SKY, Sjogren'S Clinically Active Index, which was the first one for the systemic symptoms, and it was basically derived from BILAG, and you can see here the scores of 3 and 4 like the BILAG. Score 0, the 4 is the worst, and 1 is obviously so these are the different domains. This was a predecessor for the SDI, ESSDI, but it was very exhaustive because it was borrowed from BILAG, and therefore this is the SSDAI, Sjogren'S Syndrome Disease Active Index, which came before the ESSDAI, and it had very similar to the ESSDAI, but it was not weighted. And this is the damage index which we still use. I have been using this in some of my patients for looking at damage index. This is the Sjogren'S Syndrome damage index. And so I'll now come to the main part, the ESSDI, ESSPRI, the European Sjogren'S Syndrome Disease Active Index and patient reported index. And so this is the SPRI you can see here, and this is how it is measured. You mark dryness, fatigue and pain like that is shown above. That is how you mark that from no pain. And this is an easy index, you just calculate the total. It was developed in 2011 and was validated, and you need an improvement 15% of 1 point to say that it is significant in clinical trials. Whereas the ESSDI came around in 2009, and I think the next slide is on. This is the ESSDI. What is the clinical? The difference between these two was the biological domain. In the clinical index, they removed that and gave more weightage to the muscular part, added 1 there, so the total became 0 to 135 maximum. Here it is 123. And in India, we can all use the clinical index because we don't have the biological domain always. This is the weight of these scores of the different domains, and this is the score from the domain. So you multiply, for example, if you have a constant symptom of fever more than something and you score it as 2, then you multiply by 3, so the total becomes 6. That is how you calculate this, the ESSDI. And these are the scores. So high is above 14 and low is less than 3. And you need, for a drug to be significant, you need to have an improvement of 3 points. Most of the clinical trials require more than ESSDI, more than 6 for recruitment in trials if you're looking at that domain. The most important line of the entire talk is in patients with Sjogren's syndrome, lower quality of life is mainly driven by PROs rather than systemic activity. So as rheumatologists, although we give a lot of significance to the B symptom, to the systemic symptom, because we deal with that and that is a referral bias we have, for them the most important is dryness and fatigue and fibromyalgia. That is what Dr. Fox always kept saying, that we should focus on those things rather. Now these are the areas that the ESSDI doesn't cover. So outside the circle, if you see, these are the domains. For example, Raynaud's is not covered, and these domains, if you look at these are not covered in the ESSDI. So this is just one very good photograph that I came across, cartoon that showed that those domains are not covered. What are the limitations of ESSDI? Heavily weighted domains, for example, peripheral neuropathy is a score of 6, but it's very difficult to assess damage from activity. We've seen that in practice, right? Hematology and biology are purely lab domains, and in a country like India, patients may not do it. Then you have the SDI score might decrease with activity of a domain of high weight improves, but the low weight one sort of increases. Does not take into account the gold standard clinician's global assessment. And you have high placebo floor effects. Floor effects means there are many patients who will fall into 0 and the lower categories. And this is one very interesting study which from USA, which showed that this is actually the proportion of data available for each domain. So even in USA, for example, if you want data of pulmonary from patients, this 72% had that data. So there was missing data in 28% of patients. Imagine in India. And this is true. When you actually calculate ESSD, अपने कई patient में होता ही नहीं data. So that is the problem with ESSD. This is another paper which showed that the ESSD and the SPRI actually don't correlate, because patient ka, and not infrequently you find that while the ESR has improved and the globulins have gone down, the patient says कि मेरा तो वही problem है, सिक्का and all that. So what this was work by Professor Seror from France, and so it concluded that you have to decide before the drug trial which is the domain you're going to target. Sensitivity to change was most accurately measured by the ESSDI. Responsiveness of patient score was lower than that of systemic score, obviously because they are patient-reported outcomes, but was even then better in SPRI than the earlier ones. So, and the European scores were still better in construct, validity and excellent reliability than the previous ones. And this is one of my last slides, which shows, and therefore the need for, this is the STAR, which has just come last year, and this STAR stood for, I think, Sjogren'S tool for assessment of response, and they combine the WISE for a composite index has been going on for quite some time, and here you can see the STAR carries both these. So you have systemic activity, more than 3 change in SDI, and you also have the patient reported outcome. It has to be more than 1 or 15%, and then you have the objective criteria for improvement in Schirmer's or ocular staining score. Salivary gland ultrasound has been improved. That's very important. I am not covering ultrasound salivary glands in my talk because I don't do that, but people who do that would know. But now it has been included. That is something useful for our country again, can be applied. And then you have rheumatoid factor again, levels is something we can do. Serum hemoglobins are, I think, costly, but rheumatoid factor is not so costly. So the candidate STAR response has to be more than 5. Now this is one, we'll have to still see how this fares in clinical trials. Those are some other composite indices whose suggestions that come before. And this is one Indian study, just to show you, from Madras Medical College 2016, Dr. Rajeshwari's group, which showed they applied SDI in their patients, and I think the mean SDI was around 2 as against PGI data, which was last year, which I think this year only got it published, before 1 month or something. Yeah. And that had a mean SDI of about, mean ESSDI of about 6. So your patients were definitely more of extraglandular than. And this is the left side is the one which shows the first is extraglandular versus glandular. So the extraglandular patients were younger. To the right of that is the duration of illness was also lesser, they were earlier. And then this is the SDI at baseline and then improvement after treatment. Since this is not working, I have to show for this one. This is the age difference. They are extraglandular ones are younger, they are earlier in disease. This is the mean at baseline, and then after treatment they become equal. And this is one very good by Dr. Vinod Ravindran, he in 2013, of the problems in India. So there are these patient-related problems, for example, non-affordability of investigations, they cannot measure the disease, difficulty in understanding, and also healthcare giver problems like an inward-looking approach, inadequate international collaboration, lack of patient advocacy groups, and we are not trained, many of us are not trained in doing this, time-consuming. So these are problems unique to India, and therefore what do we need to do is, so ESSDI and SPRI are still the most frequently used outcome measures. Clinical SDI is much better, but data are not available because data is not available in many, and therefore that will be useful for India. A composite index is the need of the day. Unique problems related to our country, I discussed that, and therefore the need to develop an interest group of investigators, which we now have. I invite all of you to join the Sjogren'S interest group of IRA, and from there either a new outcome measure of our own or a tweaked outcome measure according to our country's needs that suits us, like the Indian hack. We need to come out with that urgently so that all of us can assess these patients, join in a standard way. I request all of you to go to this website, Sjogren'S India. This Kirtita Oza leads this website, and to look at what we have a significant number of patients enrolled there, and so we can do some very good work jointly in our country. Thank you.
Thank you, sir, for the explaining us the various scores that we use, and also showing the difficulties in using these scoring systems.
So we'll to next talk. It's on lymphoma and Sjogren's syndrome. I would like to call Dr. Rajendra Varprasad from Hyderabad to deliver his talk.
Good morning, everyone. At the outset, I would like to thank the organizers for giving me this opportunity. And the topic is lymphomas in Sjogren's syndrome. As we all know, lymphoma is one autoimmune disease where we change the slides. Is one of the Sjogren's syndrome is one of the most is the autoimmune disease which is most highly associated with the risk of developing a non-Hodgkin lymphoma, because it is as we know, the pathogenesis. There is a constant B cell activation and proliferation of B cells along with the ductal epithelial cell activation, and these two, this constant antigen stimulation, B cell proliferation, and so this is placed at a unique place where it is at a crossroads of autoimmunity and developing into a hematological malignancy, that is like lymphomas. The lifetime risk of Sjogren's patients to develop lymphoma is 5 to 10%, which is up to 44 times when compared to the normal population. In a pooled analysis of 30,000 patients, the relative risk has been placed at 6.5, and not only lymphoma, it is Sjogren's syndrome is also associated with other hematological malignancies like Hodgkin's and other types of lymphomas and leukemias, as well as solid tumors like thyroid, oral cavity, stomach, and ovarian cancer. So this is a picture which shows how it compares with other autoimmune disease. So the first, the print is very small, but the first longest bar is the Sjogren's syndrome. It shows how many times it is at risk for developing lymphoma compared to other autoimmune diseases. The next common is autoimmune hemolytic anemia, followed by lupus and Behçet's, and then followed by ITP. So the list goes on. So coming to pathogenesis, as we all know, there is a genetic predisposition with an unknown autoantigen or external infections like bacterial or viral infections. Most commonly implicated infections are hepatitis, Helicobacter pylori, Campylobacter, Borrelia, and most recently chlamydia, which has been well studied and well established. So there is the B cells and epithelial cell interaction, which culminates into an increased risk of B cell derailment and salivary gland progenitor cell dysregulation. So this constant antigen-driven selection pushes this B cell activation into monoclonality. This is a picture where you can see there is accumulation of this autoreactive B cells, and because of the constant stimulation, because of anti-Ro antibodies and other unknown antibodies and immune complexes, and this all leads in a pro B cell proliferation milo. The polyclonal B cells move on to oligoclonal, and then subsequently they are pushed to monoclonal B cell proliferation, which finally lands into lymphomas. So it's a different depiction of the same mechanism. Initially there is predominantly T cell infiltration and B cell to a lesser extent. But as the disease progresses, the B cells, the number of B cell proliferation increases, so they tend to arrange themselves like a germinal center. It finally leads to marked lymphomas, that is mucosa associated lymphomas. So the lymphoid infiltrate is initially around the ductal epithelial cells, and it slowly grows peripherally and contains the lymphoid follicles with germinal centers. There are centrocyte-like B cells which are present in a zone beyond the mantle of these follicles, and they focally invade the ductal epithelial cells. And there is simultaneously proliferation of ductal epithelial cells as well, and they are which are infiltrated by this centrocyte-like B cells, which are active B cells. And so the gland itself morphologically will turn into almost a reactive lymph node with dissection of the epithelial architecture, and we know the glandular dysfunction. So coming to the clinical features, the whole process it roughly takes up to 6.5 to 7.5 years after diagnosis of Sjogren's syndrome. And the most common manifestation, it manifests in the parotid gland, and they usually present as a unilateral persistent swelling, fixed and hard swelling, not the transient swelling we usually see. The parotid is almost 1,000 times more commonly involved than other sites in Sjogren's syndrome. The others would be orbital adnexia, nasopharynx, thyroid, stomach, and lung. So in this picture it depicts the size of the circle, depicts how common the NHL is, and salivary gland, the two parotid being the most common site, followed by lungs, ocular, and oropharynx, and so on. So these are all called the extranodal B cell lymphomas. And all the different types we see, studies have shown that almost 90% of the lymphomas are either a marked lymphoma, diffuse large B cell lymphoma, or nodal marginal lymphoma. The marked lymphoma is nothing but marginal zone lymphoma itself. So which is the most common type. So marginal zone lymphomas can be extranodal, that is involved in the glands. splenic marginal zone lymphoma or nodal marginal zone lymphoma. And the type of lymphoma, the proliferation and the clinical characteristics depends on the site of the origin of these lymphomas. And as already told, it is commonly the marginal zone lymphoma commonly associated with mucosal sites and overwhelmingly so in parotids. They are very low-grade indolent neoplasms. They can go on for months to years. They are often multifocal in the organ involved. Within the parotid, it could be multifocal, and in 20% of the times, more than one extranodal site could be involved. And there are also studies which show that the marginal lymphomas may transform into diffuse large vessel lymphoma, which is an aggressive form of lymphoma. And involvement of marrow, as we all know, it has a poor prognosis. So the aggressive type of lymphoma which is seen in Sjogren's is a diffuse large B-cell lymphoma. It has a subacute presentation, locally infiltrative, and they can have type B symptoms. As I told in the previous slide, there is a theory that marginal zone lymphomas, they are clonally related to the diffuse large B-cell lymphoma, but there is some case report where the clonality is different in the same patient. So it is not always true that the marginal zone lymphoma are definitely are related to diffuse large B-cell, or they definitely transform into diffuse large B-cell. So how to identify who is going into lymphomas? So the various markers have been studied and proposed. What I am mentioning here are well-established risk factors. The epidemiological markers are young onset of the disease, where patient will have a longer duration course of the disease and have more systemic features, and males compared to females. And if you take the ESSI domains, the glandular domain, a chronic persistent lymphadenopathy, or the dermatological domain, where there is purpura-like rash, which is due to cryoglobulinemia, not the polyclonal gamma globulinemia. The laboratory markers, cytopenias and CD4 T lymphocytopenia, immunological markers, ANA, and it's not specifically anti-Rho and anti-La. Here it's important to understand. So many studies have shown that anti-Rho and anti-La as such, they have lesser risk or lesser risk. So it is other autoantigens apart from anti-Rho, anti-La. And well-known marker is the cryoglobulin levels, rheumatoid factor, and low complements, and monoclonal immunoglobulins. Histopathological markers include active germinal centers, but it is the definition of a germinal center within the parotid is not yet established. Other serological markers, they are recently studied, but more studies need to be, we should have more studies before taking it as an important marker. There is anti-cofilin 1, anti-alpha inverse, and anti-RGI2 antibodies. So periodical checkup of clinical and this routine investigation, which are easily available, can help in picking up these cases. So diagnosis: if anyone who has a persistent lymphadenopathy, unilateral firm, we should suspect. They may not be having lymph node involvement. MRI, dynamic contrast enhanced MRI has been extremely useful. I have a picture in the next slide I will show you. And once we suspect, only a core biopsy or excision biopsy will help to differentiate and especially if they have carries small CD5 and CD43. So this is a clinical picture. This is for representation only. This is actually a primary parotid lymphoma. You can see in the imaging on the left parotid forms filling. And this is the MRI I was talking about, dynamic contrast enhanced MRI. This has been shown to be 90% specific and sensitive. So short of biopsy, this can help if there is, it is time, there is a software for this. So time to uptake, if it is faster, here the blue line where the rapid rise. There are two types, one is a gradual and one is a rapid uptake. Time to intensity, that is what they call. So if it is high, it is more likely to be malignant. So the prognosis, overall survival compared to Sjogren's syndrome compared to normal people is not much different, and it basically depends on the subtype. Mild lymphoma, which has good prognosis compared to diffuse large B-cell, and prior history of corticosteroids and active disease and immunosuppression have a poor prognosis. Treatment is individualized and depends on the type of subtype of the lymphoma. And as I said, the marginal zone lymphomas can have a indolent course, so it is sometimes only observation is enough. But if there is any local marginal zone lymphoma, small lymphocytic lymphoma, and lymphoplasmatic lymphoma, and the early stages, that is stage 1 and the non-bulky stage, radiotherapy could be helpful with or without chemotherapy. And if it is moderate or high-grade lymphoma or diffuse large B-cell lymphoma, rituximab-based therapies is the standard of the treatment. So to conclude, Sjogren's syndrome is at the crossroads of autoimmunity and lymphoma, and the multiomers are the most common and have a favorable course. Diffuse large B-cell lymphoma are aggressive and have poor prognosis. And the predictors, what I mentioned, the predictors should be every visit we have to look at this screen for patient with clinical and for high risk patient to follow up with cryoglobulin levels, etc. complements to screen and identify early. And the treatment is individualized, depends on the subtype, but because most common is myeloma and it has favorable prognosis. And it is important, as I said, it is not different from other lymphomas, and the survival rate is quite good. 5-year survival is up to 85%, I think. So with this I would like to conclude. Thank you.
The session is open for any question and answers. Any questions regarding both Dr. Sapan sir's talk as well as Dr. Rajan's?
As Dr. Sapan sir was mentioning about Indian SDI, I would like to have a suggestion, as SDI doesn't cover a domain of fatigue, which is an important complaint of Sjogren's patient. So fatigue and assessment scores are also validated currently in Indian cohort. So if that is possible, it would be a huge difference, especially for the upcoming trials.
Yeah, fatigue becomes a patient-reported index. So, and there are actually I didn't take up fatigue because of want of time. Fatigue has been evaluated by the different scales which are only validated in fatigue and Sjogren's. There is no Sjogren's specific fatigue scale, so we can include one of those in the composite index because fatigue is a very important part. I understand what you're trying to say, and I take that point. Yeah. But पहले तो हमारा बनाए उसके बाद
Do we have any more questions? So we'll move on to the next topic, which is whether mild Sjogren's should be treated symptomatically or not. For that, I request Dr. Smriti Ramteke from Nagpur to present a talk.
Firstly, let me take this opportunity to thank the organizers giving me this opportunity. And I would be talking about should we treat mild Sjogren's symptomatically for symptoms. The therapeutic management of Sjogren's syndrome, as you all know, has not changed substantially in the recent decades, and treatment decisions remain challenging, especially in clinical practice. In view of this scenario, EULAR had promoted and supported an international collaborative study which was aimed at developing the first EULAR evidence and consensus-based recommendations for managing patients with Sjogren's. More than 95% of our patients present with Zika symptoms, And studies have shown that glandular function in primary Sjogren's report that except in early stages of the disease, this function may remain stable for long periods of time, around up to 12 years. No study has demonstrated that any therapeutic intervention can reverse glandular dysfunction. And the use of systemic immunomodulatory therapy should be restricted to patients with active systemic disease only after a careful organ-by-organ evaluation of both severity and organ damage. Baseline evaluation of salivary function is recommended before you start treatment for oral dryness by measuring whole unstimulated salivary flow before starting therapeutic interventions. We all know that it is a bedside procedure and can be done easily in our OPDs if you train your paramedical staff or even give clear-cut instructions to the patient. The preferred first therapeutic approach for oral dryness according to salivary gland function may be non-pharmacological stimulation, which is a mild dysfunction, pharmacological stimulation for moderate dysfunction, and saliva substitution for severe dysfunction. In patients with mild glandular dysfunction, non-pharmacological glandular stimulation with gustatory stimulants like sugar-free acidic candies, lozenges, and xylitol, or if you give mechanical stimulants like sugar-free chewing gums, they can be used. Now, if patient has moderate glandular dysfunction, we can use muscarinic agents like pilocarpine or cevimeline, which are licensed for the treatment of oral dryness. The 3 pivotal randomized control trials using these drugs found significant improvement in vast, dry mouth and salivary flow rates with a high frequency of adverse events. In patients who are not tolerating or who are non-responders to the muscarinic agent, sometimes choleretics or mucolytics like bromohexine can be used. According to the SLR result for the treatment of oral dryness, we do not recommend the use of hydroxychloroquine as there were no placebo differences for subjective and objective oral outcomes. So hydroxychloroquine is not effective. Oral glucocorticoids and immunosuppressive agents, there was overwhelmingly negative data with excessive side effects. And for rituximab, there was no placebo difference for subjective and objective oral outcomes in the 2 pivotal randomized control trials. So probably all the drugs are not working. Saliva substitution should be considered the preferred therapeutic approach to alleviate symptoms in patients with no residual glandular function. And the ideal preparation for saliva will have a neutral pH and should contain fluoride and other electrolytes, which is mimicking the exact composition of saliva. So the recommendations are, you see, for the whole unstimulated salivary flow, which is usually calculated by giving a patient a beaker and just asking them to sit silently, not spit the saliva, do not swallow it, and do not speak to anyone. Be relaxed for 15 minutes and collect the saliva in a beaker and just check out how much it is. Now, if it is at the end of 15 minutes, if the flow is less than 0.1 ml per minute, go for a stimulated whole salivary flow measurement, which can be done by giving something to chew and then seeing how much is the saliva which is collected. Now, if it is more than 0.7 ml per minute, then you give only non-pharmacological stimulation. If it is between 0.1 to 0.7 ml per minute, then you can use non-pharmacological plus pharmacological stimulation like adding pilocarpine. And if it is less than 0.1 ml per minute, even after stimulating, then you should go for salivary substitutes. So that is the recommendation. For ocular dryness, the first line of therapy for ocular dryness should be volume replacement and lubrication using artificial tears and ocular gels. All Sjogren's syndrome studies testing artificial tears found significant improvement for both subjective and objective ocular outcomes. While a recent Cochrane review on the use of artificial tears for dry eye syndrome showed that they are safe as well as effective. Ophthalmologists use ocular cyclosporin A drops in patients who are refractory or have severe ocular dryness or have been using glucocorticoid eye drops recurrently. And a recent Cochrane review showed that the use of plugs for dry eye syndrome, the data and the evidence was limited. For systemic therapies, again, oral muscarinic agents may be considered on the basis of improvement. Those subjective outcomes have been noted rather than objective outcomes with the help of oral muscarinic agonist. Now again, for hydroxychloroquine, there is no placebo difference for subjective and objective ocular outcomes in pivotal RCTs. Immunosuppressive agents, again there is overwhelmingly negative result with excessive side effects, and rituximab, there is no placebo difference for subjective and objective oral outcomes in the two major pivotal randomized control trials and one meta-analysis. For ocular dryness, again it's done by ophthalmologist, or you can do a Sjogren'S, learn the Sjogren'S and do it in your own OPD. Ocular staining is done if it's less than 5 or more than 5. Again, if it's non-severe keratoconjunctivitis or it is severe. So if it is severe, then they have recommended the use of topical glucocorticoids or the topical cyclosporine or serum eye drops. Oral muscarinic agents and plug insertion can also be tried. In musculoskeletal symptoms, patients with primary Sjogren'S often present with non-inflammatory joint pains, muscle pain and fatigue, and they also have a lot of depression and fibromyalgia which is overlapping, and sometimes if there is a osteomyelasic component, if there is a renal involvement. So a large retrospective study in 188 primary in Sjogren'S patients with joint involvement reported that nearly one-third had rapid response to only NSAIDs. In patients with frequent episodes of acute musculoskeletal pain, the use of hydroxychloroquine has been proposed based on its comparable use in other diseases like lupus. Although uncontrolled studies have reported improvement in joint pain, the pivotal randomized control trial failed to demonstrate that hydroxychloroquine improved pain after 24 weeks of treatment in comparison with placebo, although a statistical trend was reported. Data from two pivotal randomized control trials on the effect of rituximab on pain and fatigue reported no significant difference in comparison with placebo for both pain and fatigue VAS. A small randomized control trial using anakinra found no significant reduction in fatigue in its primary endpoint, while the promising results were obtained in two small open-label studies. But this is something very interesting, that a small case control study in primary Sjogren's patients showed significant improvement in aerobic capacity, fatigue, and ratings of perceived exertion and depression in patients allocated to the exercise group. Treatment of systemic disease, it should be tailored to organ-specific severity. Glucocorticoids should be used at the minimum dose and the length of time necessary to control active systemic disease. And the recommendation is that glucocorticoids should be used at the minimum dose and a small span of time. Thank you.
Thank you, ma'am, for a brief overview of the treatment in Sjogren's syndrome. Now I request my co-chair, Dr. Pramod, to summarize and give his practical tips regarding the same question.
Thank you, everyone. At the outset, I would like to thank the IRA and the organizing team for providing this opportunity. Yes, should we treat mild Sjogren's syndrome only symptomatically for Zika symptoms? This is the question which has been raised. There is no slide. So let's look at the practical tips for this. Slides are on. So answer is very simple, either it is yes or no. So if you look at all the recommendation and the guidelines, as Dr. Smriti already highlighted, the answer is yes, they want to treat only symptomatically for the Zika symptoms. But to be practical, we need to look into the underlying pathology as well as other supportive evidences. So pathology clearly states that there is an infiltration which is going on into the glands. So a lot of polymorph cells are into these glands, and there is definitely the destruction of the glands which is ongoing. So just by treating the patient's Zika symptoms symptomatically by just replacing the tears or artificial salivations, does it going to solve the problem? So if we look at other supportive evidence, no definite evidence we could find for the efficacy and safety of use of systemic immunosuppressions, but the indirect there is a lot of evidences, especially in the setting of lupus as well as secondary Sjogren's, which is associated with rheumatoid arthritis. So if you look at glucocorticoids, again benefits are well known as far as considering the reduction of the glandular size. So that again indirectly tells us that a lot of infiltration which is going on into the glands is going to be reduced if we start using some systemic immunosuppressions. But there are no large trials which is supporting this. And if you look at hydroxychloroquine, there is a lot of evidences which we gain from the lupus. So in the lupus setting, the role of hydroxychloroquine is very well established, and there are some open label trials which have shown some benefit in terms of arthralgia as well as myalgias. And when we come to the methotrexate, yes, one pilot study showed an improvement in dry mouth as well as eye symptoms along with arthritis and arthralgias. However, no objective parameters improvement has been noted. Cyclosporine systemic usage has also found some improvement as far as dry mouth at the end of 6 months. Coming to the rituximab, of course, the two major landmark trials of Sjogren's, that is practice and tears, have established no definite evidences of usage as far as Zika symptoms concerned. But we need to look into this data more clearly and more in depth. If you look at this, though not a statistical benefit, but there has been a significant improvement as far as unstimulated salivary flow has been considered in practice, and significant even improvement as far as dryness and fatigue in case of tears. So there are few other randomized trials, though small in numbers, but they have shown that salivary secretion and visual analog scales as far as oral and ocular dryness in rituximab is concerned has definitely shown some improvement. Even open label trials have shown, they are definitely, we agree that they are in small numbers, but they have shown, like if we use rituximab, there has been considerable improvement in their Zika symptoms and considering the patient outcomes as well. So long-term safety of rituximab has been studied also in quite a recent trials, which have shown well tolerated and have even significantly reduced ESSDI. The more recent phase 2 trial, which has already come up with rituximab along with usage of belimumab, which has also shown a very good significant improvement as far as the improvement in Zika symptoms are concerned. So I would like to consider definitely supportive treatment is very much essential as far as Zika symptoms, and we don't have a significant backup with evidence to show that we need to use immunosuppressions, but there have been very good articles and studies which have shown considerable improvement as far as Zika symptoms. So practically even I think Dr. Sapan sir can highlight on this. If we can use glucocorticoids and see if the patient is really improving, and probably I think adding up immunosuppression to them would be really of help. Thank you.
Thank you, Dr. Pramod. So if you have any one comment or question, we can take. Yeah, so okay. Thank you all for the patient hearing. So that can be evident, lot of people now compared to starting of this session. So